Welcome to the Mayo Clinic Ophthalmology Podcast, brought to you by Mayo Clinic. I'm your host, Dr. Andrea Tooley.
And I'm Dr. Eric Bothan. We're here to bring you the latest and greatest in ophthalmology, medicine, and more.
Today we are joined by Dr. Pratish Tosh, an infectious disease specialist here at Mayo Clinic in Rochester, Minnesota. Dr. Tosh talks us through all of his fascinating work on emergency preparedness, cybersecurity, risk management, and everything you want to know about mitigating risk from a big healthcare perspective down to an individual. Stay tuned. Dr. Pratish Tosh is professor of medicine and infectious disease at Mayo Clinic in Rochester, Minnesota, and the medical director of risk for the Mayo Clinic enterprise, overseeing integrity and compliance, internal audit, operational risk management, enterprise risk management, business continuity, emergency management, security, and information security, if that's not enough. His clinical work is focused on emerging infections, infections in patients with cancer, infections in patients with critical illness, and ambulatory infectious disease. Welcome, Dr. Tosh.
Hey, thank you for having me. This is exciting.
What a resume. We're so happy to have you here.
Thank you. It sounds like it was somebody else, but I guess that's the stuff I do.
It's awesome.
You're one of those colleagues that when I see you in the doctor's lounge, I know that the conversation's going to be interesting.
Yes.
I'm going to learn something and laugh. So
Thank you.
To have you as a guest is a particular joy, and I think you'll be able to bring those elements to our listeners.
Great.
Yeah, we really want to pick your brain about all kinds of different things in terms of what you do clinically and then what you do here at Mayo. And I think we'll just start, a lot of our listeners are comprehensive ophthalmologists. And so tell us about your life as an ID doc. What's been your path, your journey? Kind of give us your little overview. How did you get to where you are today?
Thank you. So I had not to say a circuitous route, but an unusual route, because my whole interest was sort of in risk, which no one else wants to do. Like, no one likes to think about bad things happening. I always thought about bad things happening, but thinking about, well, what can we do about it, right? There's no point in thinking about asteroids falling, because, I can't do anything about that, right? So in medical school, I had this mentor, and that's how everything starts. You have a great mentor. At the time, I was the president of the graduate and professional student body at the University of Missouri, and the faculty president, again, for the whole university, was an infectious diseases doc, Dr. Gordon Christensen, who has unfortunately since passed away. But I remember going to all these meetings and seeing him and just how he would conduct himself and how he thought just so much bigger than just what was in front of him. Mm-hmm. And I guess that's how it works with mentors. I'm like, you know what? I like that guy. I want to be that guy. Mm-hmm. And I realized, wow, these infections are kind of cool, right? That it's not like the heart. And as two ophthalmologists, I'll pick on cardiologists.
Perfect.
We keep learning more and more things about the heart, but the heart's not changing, right? Mm-hmm. Whereas infections, we have to learn more about the things we know, but the infections keep changing too, right? Completely new viruses popping out of nowhere, and so that was always just really, really cool and a cool challenge. But what Dr. Christensen had told me about early on was this program at the CDC called the Epidemic Intelligence Service. Yeah,
that's like the CIA or something.
It's really cool stuff. And yes, I had security clearances at the time, and it was military. But essentially, so I did residency, came here at Mayo Clinic for internal medicine. Then I did infectious diseases fellowship at Mayo, and it was great. And I loved it, and I did basic vaccine work. But then my second fellowship was at the CDC in the Epidemic Intelligence Service, and that is as cool as it sounds. Because for 2 years, I went across the country, and some people went across the world, but me, they knew I think the term was delicate. I think that they knew I was delicate, and so I only did domestic outbreaks. And so went, and mostly because my interest was in healthcare organizational preparedness, right? And so that's exactly what I did for 2 years. Chasing down outbreaks, putting a stop to those, and at the same time learning about how you build resilience for a healthcare organization. And thankfully, I was able to come back to Mayo, and Mayo was like, you've got some very unique skills, but we'd like to see you do more. And so then I was a Mayo Foundation scholar for an additional 3 years, where half time I was clinical, but the other time I was working with Mike Osterholm at the University of Minnesota. at the Center for Infectious Diseases Research and Policy. And if none of you on the podcast are aware of Mike Osterholm, just Google him and just look at the first 10,000 hits that come up. He's a big deal. And like to be able to actually work with him was really amazing because I learned about the big picture, right? Like how food security and water security can impact health, right? Mm-hmm. And what it takes to get a vaccine from a petri dish, like all the way through, funding and FDA into somebody's arm. I learned about global supply chain vulnerability, and like all of these very big picture things that impact, when it comes down to it, a single individual, right? And that if we're going to impact a single individual, the system, whatever systems we currently have, are perfectly fine-tuned to get the outcome you are currently seeing, right? And if you want to change the outcomes you're currently seeing, you do have to make an impact for the whole system, right? And that was a really illuminating time. And then I finished that in 2014, just in time for Ebola.
Perfect.
Right? And so there's a lot of like serendipity with my career. So I was the medical director for emergency management as this thing started to trickle up from West Africa, and I helped lead our preparedness for this emerging infection. And then at the time we realized Ebola, but then other things started coming, and we didn't really have a word for it. Like people were saying special pathogens. All right, why is it special? Highly infectious agents, well, they're not really that infectious. So I actually coined the term high consequence infectious diseases, HCID, around 2014. And now what I like seeing is it's actually taken off. Have you seen the movie Mean Girls?
Of course.
Yeah. I feel like I made fetch happen. Like
Yes,
whenever
exactly.
I see HCID in print and something
Yes,
I didn't write,
it happened.
like I made fetch happen, right? It was so cool. But then
That's
I started,
awesome.
thinking, well, more big system stuff. I remember in 2017, right? Not 2020, right?
Yeah.
We were thinking, man, if we have a pandemic, and of course we were thinking about influenza at the time because I wasn't even thinking coronaviruses. Like, what do we run out of first, right? So we did this Monte Carlo simulation where we looked at 10,000 different pandemic scenarios. And like, well, what do we run out of first? Staff, space, stuff. Which staff, which space, which stuff? Can you guess what we would run out of first?
I mean, with COVID, it was ventilators,
Staff. Oh, you mean
masks.
equipment?
Oh,
And
staff.
N95 masks.
Yeah,
masks,
masks.
Early, right?
Yeah.
And so we, and this is I'm grateful to Mayo. I went to our hospital practice. It's like, we're going to run out of N95s quickly. And, the cost is a lot to actually start to stockpile, and Mayo and their wisdom was like, yep, let's do it. And
Wow.
it was like $1 million up front and then 20% subsequently indefinitely. But the reason we had enough masks up front was actually because of the wisdom of Mayo and the folks involved with this to think far ahead and like, you know
Wow.
what, if we have something, we really want to be able to take care of our patients safely. Right?
Phenomenal.
Phenomenal, right?
Yeah.
And so there was no, after that, like I wasn't going anywhere, right? Like,
Yeah.
and Mayo invested in me when I was talking about, crazy things coming out of Africa and pandemics when those things weren't happening, right? And then later on, I just got more engaged in business continuity. Like, well, yeah, we can respond, but like, how do we build our resilience so that we don't have to have Herculean efforts, right? How do we incorporate just basic business resilience into our daily work so that when something happens, we have just more elasticity, right? We are able to respond more quickly.
What does that mean?
That, for example,
Yes, give me an example, please.
if you think about what are all of the core functions for life-saving stuff in ophthalmology, right? And I'm sure you can rattle off what those things are. And what do you need to have that happen? What people, what staff space and stuff do you need, right? And what if that staff space and stuff doesn't exist? Do you have a backup plan? And is your backup plan the same thing as somebody else's essential backup plans? In which case we have a problem, right? So understanding, well, what is our core function? and what does it take to sustain that core function, and then what do we have to do to build up some resilience, some flexibility in what we do daily, so that we are able to better respond in case things go down.
Wow.
So how many large organizations like Mayo, would you say have that sort of team thought going on a regular basis?
So it's common, and you will find it much better in for-profit industries because they can see the future, right? I will tell you that Ford Motor Company knows exactly where their supply chain is coming from and wants resilience built into it. It's a little tougher for nonprofit organizations because, these things are rare, right? Mm-hmm. But when we're talking about human lives, right? And unfortunately, these things keep happening. I think a lot of places are, if they're not already have some level of maturity in business resilience, they're really looking to get there. We are, for ourselves, we are not as good as we want to be, but we have a plan in doing that. It's just like the best time to plant a tree was 20 years ago.
Exactly.
Second best time is right now. Right. So even if places are not thinking about that, they should start thinking about that, especially if you're going through a pandemic. Yeah. They already have the bare bones of what they kind of need.
Well, certainly, I think even our practices, during the COVID journey, supply chain got disrupted on so many levels, but personal and professional. But nowadays, it seems like it's more common than ever that there'll be a stitch type of suture material that's not available, or a type of drape that is not available. It's just
or fluid, IV
fluids.
fluids.
IV fluids.
We're out of right now.
Yeah.
So it's just become a more heightened awareness over our need to adapt. But as you're highlighting, the need to be proactive.
Yeah, and it's not just response, right? It's preparedness. And for global supply chain, just thinking about the big picture, right? So 7 years ago, Mayo, actually now 8, we started the Healthcare Industry Resilience Collaborative. Now there's, thanks to the pandemic, about 100 different organizations that are trying to fix the supply chain problem by fixing the underlying incentives to incentivize those that are more resilient, have more resilient products. But that's another podcast. So as I started building more about business resilience, and then I got brought into a lot of this stuff. Well, security and information security starts to build. Then I got involved in business in security, information security, and then as people got to know me, they asked me about privacy, and eventually it's just all a risk. And so I haven't really had any formal mentors in healthcare risk because we just don't exist. I'm sure I'm the only person the only physician who's focused their entire career on organizational risk. And organizational risk is not just knowing what to say no to, right? It's really understanding what the risks are and knowing where to take risks, right? Have you guys ever played blackjack?
Yeah.
Mm-hmm.
Okay. And pretend that blackjack is a winnable game, right? My role is to see, okay, what are all the possibilities and where can we go wrong? And you know what? If you are dealt 11, we should be doubling down, right? You double down on 11. You're not going to win every hand, right? But understanding what the risks are. And frankly, in 2025, in healthcare, moving as fast as it is, the biggest risk we have is doing nothing, standing still, right? And so we have to really understand the risks we're taking and take good risks. Mm-hmm. And that's what I'm excited about, that healthcare risk in 2025 is not just saying no, right? It's figuring out how to say how, right? These are the problems, and then how do we work around this, right? How do we maybe there are some risks we can eliminate, maybe there are risks that we can mitigate, and some we just have to accept, right? But understanding how we do that holistically, that's been a really cool piece. And that's me now.
That's so cool. I love this. One thing that I want to ask you, Dr. Tosh, and I don't want to jump into a whole COVID discussion. I think we've belabored COVID so much, and I'm sure you're COVIDed out. But it seems like, your whole life you've been preparing for this moment. And then the pandemic happens, and it's almost like those doomsdayers who've been storing and prepping, and then like finally the end of the world happens. So how does that feel to someone in your shoes? Is there I don't want to say excitement where you're like, oh, finally my skills are going to be put to use, or is it even more disastrous because you know what's coming? Like, what did that feel like when you saw the pandemic coming from everything you knew?
I did a podcast here right as the pandemic was really about to roll, and we knew that it was no longer like an isolated outbreak. And I watched this in slow motion, and it did not feel good because, I had been working towards this sort of thing for a long time and building Mayo Clinic's emergency management. And our emergency management went really, really well. We were able to respond, and we were able to be pretty nimble to help us navigate all this stuff. But for about 3 or 4 months, I was sleeping 4 hours a night. It was really hard, right? So I would go to bed at about midnight after answering emails, and then wake up at 4 to answer the emails that came in after midnight and need an answer by 7. And so that was the hardest time of my life. And I don't think I knew what my limits were. I don't think I knew what my limits were ever in life until the pandemic, where I realized, and there was a moment where I just sort of cracked, which I was like a frog in boiling water, right? And thankfully it was with a colleague who understood me. And I remember she saying, "You must be under a lot of stress. Have you thought about asking for help?" And I felt like I was suddenly in Hogwarts, and like help will always be given to those who ask for it, right? And then I just started asking, and people were like, "Oh yeah, of course, let's help you out," right? Wow. And then I got everything I needed, and I was able to really focus on what I needed to do, and was able to let other folks take the other responsibilities that that I didn't train for years and years for. But yeah, it was a really hard time. But I realized that I was able to, because I did so much ahead of time, people looked to me, and I didn't take that responsibility lightly. But also, I think largely we were successful, and I think people saw what I was able to do in a crisis, and then gave me all these other jobs.
So in that, the ignorance is bliss for many of us. Some of us just stayed home and hunkered down and waiting for each of these steps for the organization to share with us what is the next step. During that journey, there was fear.
Yeah.
But going back to your question a little bit, the more you know, sometimes the more you worry. And it just, in your job, understanding the threats to an institution, but even to human existence, but how do you balance that sense of knowledge that could drive you to concern versus what you said at the beginning of the podcast, which drove you from the beginning, is what excited you, as you said you like to address that risk. What can you do to fix it? So how have you, through the COVID journey, balanced the fear of how bad can this be versus what can we do going forward? What was that like for you? And separate from the I can't sleep, I can't work, I don't have enough help, but just internally.
I don't know what to say except I've always been like that, right? That I try not to focus on things I cannot address. And I'm realizing there's a lot of things that are actually within my abilities. Whether it's addressing global supply chain vulnerability, how do you impact the big picture, or ransomware, but I can't impact a meteor, right? So I don't think about it, but rather, what are the impacts, right? And if we think about, and you can think about, let's say, structural damage from a fire or a tornado or anything, but it still comes down to you have a space problem, right? And how do you protect your people? And so it's very, from my end, very basic. But thinking about it in very basic terms and thinking about what you can do about it. And I tried to spend very little time thinking about things I can't do anything about.
Now, we started this podcast talking about all of your hats, and certainly a big part of this, learning about risk management and learning about preparedness, and then COVID's been a big part of this journey. Remind me, but for our listeners, what are the other aspects of risk management in an institution like Mayo? You have this sort of infectious disease preparedness, but what are your other hats exactly? Where do you spend the bulk of your avenues?
Well, now it's mostly administrative, right? And thinking about the big picture, but things like privacy, integrity and compliance, enterprise risk, which I'll get to in a second, business continuity, emergency management, physical security, information security. But the big thing about my role in risk is really understanding all the things that we are doing as an organization, things that are new and potentially have risk involved with it, and understanding those risks, seeing what we can do to get what we want out of it while minimizing the risk, or understanding this is such a high value thing, we just have to accept the risk with an understanding of what that is and what the consequences are, and being able to prepare to handle those. So what I'm doing now is, overseeing a lot of those silos of excellence, but also really helping Mayo to navigate the risk landscape of everything we're doing and make sure we can take the right risks as an organization as we try to move forward.
This is all very kind of broad, and it's hard for me to understand what it all actually means.
Sure.
Are you able to give some examples of threats or current things that you are working on, or like what is the actual concrete stuff?
Yeah. So some of this is proprietary.
Of course. And what are big risks to healthcare organizations in general?
Let's just say, let me take an ophthalmology clinic, right? What are their risks and of things that they're doing? Well, there's, of course, privacy risks. Let's say their electronic medical record, somebody accesses it, right, and distributes somebody's healthcare information, right? Or let's say there's spousal disputes and things like that, or custody issues and things like that, and so how do you protect your healthcare, your health record, but also, how do you keep your employees safe, right? How do you, as we're becoming more nimble with electronic health record, right, and want our patients to have ownership of of their health, right? How do we keep that whole system from getting hijacked, right? So if you're rolling out a new technology to connect with patients, well, do you even understand where that information is going, right? If you have a point of care ultrasound, right, and it's generating images, do you know where those images are going, right? Like, who else is getting those, right? And who else can connect to that database and all this stuff, right? So as we're advancing health, there's a lot of questions that come up about what we're doing. And so that's where, frankly, risk management comes in, to really understand, okay, this is obviously a huge, whatever the widget is, new technology is, upside, but let's understand what the risks are, see what we can do to mitigate those risks, and if there's some risks we cannot mitigate and cannot eliminate, do we just have to accept the risk because whatever new product this is just so great, it's going to change people's lives.
Now, in doing that, I know, like here at Mayo, we have certainly a level of onboarding that new employees get to understand processes, and there's software things that monitor for protective health information pieces. And we have our fire drills or our modules we take every year to know how to handle a spill or this type of needle or that type of needle, protective wear when we interface with certain patients. What is the biggest barrier in your sphere then? You're realizing you want to change the OR practices about the handling of a certain gown wear or the lack of mask, or maybe it's fire preparedness, whatever it is. But I mean, I imagine that to me, the biggest barrier has got to be in some way getting people to change.
That's exactly
So in that, whether it's changing your password, I mean, I have to admit, how many of us have the same password on 4 different or 18 different access?
We'll talk about that later.
Yes,
Yep,
give us the password tips.
But what about, how in an organization have you found, because listeners here are maybe in organizations that are asking them to change their practice, and they may or may not, but also some of our ophthalmologists are leading their individual private practices. And as they think about managing the risks in their practice, they have to ask people to change. So what have you learned in people management, in getting change for the purposes of protection within an institution?
So Eric, I'm a storyteller, and I'm going to tell you a story. So I've learned about I learned a lot about this change management through a friend of mine who is a cognitive scientist, and his PhD dissertation was essentially that if you understand what somebody knows and understand their motivations, their actions will never surprise you. And if somebody's actions surprise you, you either don't know what they know or don't understand their motivations. This is true for children. This is true for schizophrenics. Like, what a schizophrenic knows may be totally wild. And what is motivating them may be completely alien to you. But if you understood those things, their actions would make perfect sense. So as I navigate change management, if somebody is responding in a way that doesn't make sense to me, because obviously I'm trying to drive us towards something, then I don't understand what they know, or I don't understand their motivations, right? And maybe I'm trying to get them to change their OR practices, and maybe they know that these OR practices have led to better patient outcomes or less utilization of resources. There's a lot of things that maybe I don't understand. So the first thing I do is, okay, I'm getting resistance. I'm not knowing something. And maybe I do know it. And then the issue is, okay, maybe they don't know something, right? And then what is motivating them versus what's motivating me? And so if I can understand well what people know and what motivates them, I can usually figure out a way to get them to change, frankly. But I mentioned that I did improv for 8 years, and as I learned more and more about Homo sapiens, us as a species, I realized the power of storytelling. Have either of you been to Hawaii?
No. Gotta go.
You gotta go.
I know.
Wait for the kids to get a little
Exactly.
bigger. Although we took Lydia when she was like just over a year old. Anyway, the Hawaiian Islands. So the Polynesians were the greatest explorers our species had ever known. Like the entire South Pacific, they explored just with their knowledge of the stars, wind, waterways, looking at birds. The Polynesians had no written language. They were able to do this over centuries through the oral tradition by telling stories. And it turns out, like, we like to think of ourselves as physicians, like we're numerate and literate, but it's only in the last 2-3 generations that the majority of Homo sapiens on this planet can read and write, right? It's for 200,000 years that we have relied on the stories of our friends and our elders to tell us about these things. And so we are sort of innately storytellers. And I never come back with resistance with numbers, right? I always come back with a story because that's what resonates. Honestly, if you were to buy something off Amazon that your friend was like, this is the lemon olive oil, whatever. This is the best tasting lemon olive oil. And you go on there, it's like 3 stars. But you're like, well, my friend whom I trust is saying this is really good. I'm still going to buy it, right? Even though the number in front of me is telling me this is terrible, right? But honestly, if a good friend whom I trust is telling me this is the best lemon olive oil, I'm going to buy that thing, right? That's because I am, frankly, we are only capable of being numerate and literate in a very narrow band. And for my band, yeah, it's healthcare risks or clinical infectious diseases. But I realize that outside of that band, like, I'm very prone to storytelling. And so how do I overcome things? It's usually through storytelling, talking about, for example, I'm trying to get people to use longer passwords, right? It's very, frankly, because our systems are so tight, healthcare organizations like ourselves, usually the way that bad guys get through is by people and just sort of social engineering. And so we are sadly the weak link, and it's easy to talk about these are all the healthcare organizations that went down, patients that were impacted, and money that was lost because they didn't have secure passwords.
Let's end on that, because this is a big part of your recent life too. As I understand, you've understood how bigger systems have learned to protect themselves better.
Yeah.
But I remember you were sharing with me at a recent discussion that there are other smaller healthcare systems that don't have the resource to have these really strong internet security systems that are breached and it changes the whole landscape of what we're able to do and feel protected. And you're studying that, in my understanding, to try to figure out how to communicate to others how to protect themselves. So share a little bit about what that means in your life and what advice you have for people that own their own practices.
And I will get there.
Okay.
Another story, and I'm sorry. Do you guys remember about 10 years ago, like all these retail agents, all these retail companies got hit, right? Mm-hmm. There was all these security breaches, like Target, Home Depot, just on and on. You don't hear about that recently, very, very much. Not like we did 10 years ago. What happened was the credit card companies were like, enough of this, right? If you don't have certain basic information security backbone, we won't process your payments. Then all the retail, in order to do any business, you have to do this, right? In risk, it's easy to think about, okay, I have to be the fastest gazelle. Usually you just have to be the second slowest, right? As long as you're not the slowest gazelle, you're probably fine. And so what happened was, and people like to think about cyber criminals as like a good versus evil, right? And that is a sort of childish, cartoonish way of thinking about humans. And if you think about it in terms of these are people with skills who need to feed themselves and pay rent and maybe put their kids through college, right? And maybe some moral ambiguity. They don't see the difference between using their skills to say ransomware of a healthcare organization versus, I don't know, Best Buy or something like that. And so for them, suddenly all these retail stores were just faster, right? In terms of the gazelle is faster. So they moved away from retail to healthcare, right? Because there's a lot of money in healthcare. And the information is really valuable, right? Private information, and what the operations are very valuable. People's lives are at stake, especially if you're looking at a hospital, right? So this has become prime. I already told him, but do you know what of the healthcare organizations that get hit with ransomware, the median size in terms of employees? Give me a guess.
Oh, I don't know, but I'm guessing it's going to be small.
Yeah, 450.
Okay.
That's the median.
Yeah.
Everyone thinks about going after the big ones. No, it's a lot easier to get a couple bucks here, a couple bucks here, there, than try to go for somebody who is far more sophisticated. And so small mom and pop shops, single ophthalmology clinics who think, well, why would a Russian cyber goon go after my clinic, right? Well, that's exactly who they're going for, right? And popping them off just one at a time. This is the slowest gazelle. And so for Mayo, for me, yes, I can think about how do we strengthen our own cybersecurity posture, but then I think about the big picture. The reason healthcare as an industry is a target is because we are the slowest gazelle. And I don't have to make the fastest gazelle in our flock any faster. I have to make the slowest gazelles just a little faster, right? And right now, I don't know what, if let's say someone has $10,000 to spend in a small clinic, where they should spend $1 and where they should spend $10,000, right? In terms of the best bang for their buck. We can always look at what their risk is and what the risk exposure is and what it's likely to cost them if they don't do anything. But that's what we're working on next, is like for a 50, 500, 5,000, 50,000 employee organization, where is the best bang for the buck? Where do they start to get diminishing returns on their cybersecurity investment? And it is an investment. Frankly, I want people to make a good financial choice for themselves, that it will actually save them money and then insure the rest. And so I'm working with folks, I don't want to name them because I didn't ask them if they can be on this podcast, who have that data broadly, and folks who are able to analyze that data, and us who to do something with it, to actually let people know this is where $1 goes, this is where $10,000, 100,000, 10 million, so that as an industry, we can strengthen our the healthcare industry. So frankly, the ransomware folks look elsewhere, like they did with retail.
Fantastic.
What a world you live in.
Yeah. Wow. I have nothing to say. I wanted to ask you some kind of private practice hacks, or what would be your big kind of lowest lying fruit, but you kind of just said that it depends on how much risk you're willing to tolerate, how much you have to spend, how much you want to do. What would you recommend to a kind of private practice, small clinic owner?
Because I imagine many of them are not involved, unless there is a level of resources that they tap into that I'm not aware of. But yeah, what would be what's this first step to do more tomorrow?
So one is they don't need their own cybersecurity person, right? There are groups that will, collectively manage a bunch of people, right? And they will tell you, okay, look, this is what it's going to cost to get to this level, right? But all you have to do is not be zero, right? You don't have to be just don't be the slowest gazelle, right? And then that suddenly makes things a lot better. So the ophthalmologist does not have to be an information security expert, right? But they should find someone who's doing this and doing it in healthcare. And there are folks who are very willing, for a small fee that will end up saving you a lot of money in the long run, help you.
Yeah.
Right. And if you have software, it doesn't help that it's on the shelf. It's not shelfware, right? You need to be able to actually turn this stuff on and use it. And once your systems are secure, just being not to say paranoid, but just be cautious of the external emails that come in, especially if they ask you to click on something. If it's helpdeskmicrosoft.com does not exist, right? That's a scam, right? And just getting people, sort of training people to do that. But that's where having long passwords and that sort of thing is where it comes in.
How about personal hacks for risk preparedness mitigation outside of work?
Yeah, so the thing about cybersecurity,
besides long passwords.
So it's so hard to not, because they're like, okay, I'll use this. I have one long password to remember. I'm going to use it on everything, right? That's terrible too. So there are these password managers.
Yeah.
And those are relatively cheap. And gosh, it's been so helpful. It'll generate a random 20 character.
Is the one your phone does okay?
Yeah.
Okay.
Well, I have one. I mean, it's on my phone, but so it's that way. I literally only know 2 passwords. I know the password to my password manager,
right,
that has all of my passwords except my Mayo password, and then I know my Mayo password. So I just know 2 passwords.
Okay.
And so none of the passwords I use are the same, but I don't have to keep making new ones. I just use a password manager for all of my non-work stuff, and it's made it really easy.
Outside of cybersecurity, any other risk hacks you recommend on a personal level? Should we be stockpiling masks and water and?
The first thing is water.
Water.
Actually, the first thing is safety, right? So, you in your own home, do you have
A place to go.
a place to go, right? And then do you have, so in my own home, I always have 7 days of basically potable water that's stored, and then a month of emergency rations
Yeah.
that I cycle through every 5 years. This stuff tastes terrible, but
Does it?
That's the basic stuff. And
Okay.
then having a radio and a way to power your phone.
Okay.
Right. So a solar powered, so I have a solar powered charger and I forgot what is a, anyway, a way to boil water.
Okay. No, this is great.
Yeah.
Yeah.
I mean, but there aren't many.
This is your job.
It is,
Like,
it
how
is.
could you not?
There aren't many jobs for paranoid extroverts. Right.
You found your
You found
place.
one.
Right, like this is like
This
you
is
know,
it.
leadership and risk, and like serial killer. Those are the 2 jobs for paranoid extroverts, and I think I chose wisely.
Well done. Well done. Well,
Well-
Dr. Tosh, incredible. Thank you so much for all this information. Really wonderful. Learned so much.
Yeah, it's definitely a world that I think we can all appreciate that you were
Yes.
at this, at the forefront, helping to lead, and certainly sharing that with our listeners today has been appreciated.
All right, thanks, man.
Thanks for all your
Thank
work.
you. Thank you.
You can find all episodes of the Mayo Clinic Ophthalmology Podcast on our website.
Thank you for listening, and we definitely look forward to sharing more